Next, we'll move on to nephrotic syndromes. So, under nephrotic syndrome, the first one and the most common one will be the minimal change disease. So, this is the, as the name suggests, there is going to be very little change in the glomerulus as such. That is why it is called as minimal change disease. The other names given for it will be a nil deposit disease, because there is not going to be any kind of deposition in the glomerulus. So, it is also called as nil deposit disease. This is the most common nephrotic syndrome seen in children, and usually it affects 2 to 6 year old children. More than even adults can be affected, but most commonly in the children. So all of us must have seen nephrotic syndrome cases during our pediatric posting. So remember that here the pathology is basically immune dysfunction related to T cells usually. So there is going to be various diseases which cause this immune dysfunction. So what are the causes associated with minimal change disease? Usually a kid, they'll have a classical history associated with atopy, or even they'll have some vaccination history or recent respiratory tract infection, or even a Hodgkin's lymphoma. So this kind of history can be given in a child, following which the child is going to develop a nephrotic syndrome. That means that they are referring to a minimal change disease. So here what happens is, the negative charge which I mentioned of this filtration membrane is going to be lost here. So negative charge is lost. So what will happen? Negatively charged proteins like albumin, they can be filtered through the glomerular basement membrane now. And here, this is the only nephrotic syndrome where there is a selective proteinuria for albumin. So only albumin is being excreted. So it is called as selective proteinuria. And rest of the nephrotic syndromes, it is usually non-selective proteinuria. Other proteins as well as albumin is going to be excreted in the urine in other nephrotic syndromes. And the very important thing about minimal change diseases, these kids are going to respond very well to corticosteroid therapy. That is more than 90% they respond. While adults, if it is an adult presenting with a minimal change disease, they don't respond that much. And some percentage of adults presenting with minimal change disease can progress on to a renal failure also. So what are the findings we see in a minimal change disease? On light microscopy, as I mentioned, there is not going to be any change. That is why it is called as a minimal change disease. While only one change we can see, that too in the proximal convoluted tubules. So in the proximal convoluted tubular epithelium, we can see deposits of this lipid. So they are going to appear like clear vacuoles, and this is called as lipoid nephrosis. So lipoid nephrosis is the other name given to the minimal change disease, because there is going to be hyperlipidemia with lipiduria in this nephrotic syndrome. So remember, I told lipid cast, lipiduria and all in nephrotic syndrome. So because of that, the lipid which is being excreted, they can be seen inside the tubular epithelial cells as vacuoles, which is called as lipoid nephrosis. And as the name suggests, it is a nil deposit disease. So there are, on immunofluorescence, there is going to be no deposition. While on electron microscopy, if you see, there is going to be the only change you see in a minimal change disease will be on electron microscopy, and that is diffuse effacement of the food processes. So this is the podocyte layer. So all of these podocytes, initially we were drawing it like this, right? So it was all like this. But now how it is looking here, it is all looking like a fused and a flattened kind of lining, right? So this is called as diffuse effacement of the food processes, which is classically seen in nephrotic syndrome, especially minimal change disease and FSGS. Okay. And this is the only feature we see in minimal change disease. Next, we'll move on to the next type of nephrotic syndrome, which is membranous nephropathy. So, membranous nephropathy will be the most common nephrotic syndrome seen in elderly people. So, here we have two types of membranous nephropathy, primary and secondary. Primary is the one which is autoimmune. Now this is a very recent update. So primary, initially it was considered to be idiopathic, but now they had found the reason for this primary, and it is actually autoantibodies directed against certain target antigens present in the glomerulus. So these target antigens are nothing but thrombospondin domain 1 7A. So this is THSD 7A. So against this, or neutral endopeptidase, or the most commonly phospholipase A2 receptor. So this is going to be the most important one, phospholipase A2 receptor. So against these proteins, we are going to have autoantibodies, and these autoantibodies are going to be of the IgG4 class. So all of this is very important. So IgG4 is going to be directed against this thrombospondin, then neutral endopeptidase and phospholipase A2 receptor. If you measure for these autoantibodies, the levels of these autoantibodies are going to correlate with the severity of the disease. So they are considered to be biomarkers for this disease. If the target antigen is a neutral endopeptidase, it can result in neonatal membranous nephropathy. Okay, remember that N for N. Okay. And the phospholipase A2 receptor, I need to mention one small thing. Previously, in mouse models, they found out there was a Magellan antigen, and against this Magellan antigen, the autoantibodies were formed, and that was called as Hayman's nephritis. So, this model in humans is the one which they had found it as primary membranous nephropathy. Okay. So, this phospholipase A2 was the counterpart of this Magellan antigen seen in rats. Okay. And here, in secondary membranous nephropathy, we are going to have various causes. Again, I mentioned causes of all the nephropathies will be important. So, drugs like NSAIDs, gold, penicillin, captopril, all of this can trigger a membranous nephropathy. Then, cancers, it's an elderly people, right? So, any cancers they have like colon cancer, lung cancer or a melanoma, they can also trigger a membranous nephropathy. Then, other connective tissue disorders and autoimmune disorders like SLE and infections like hepatitis B, hepatitis C, schistosoma, malaria, syphilis, all of this can present with a membranous nephropathy. So, some of these causes will be an overlap between membranous and membranoproliferative nephropathies. So, I'll be telling that in detail again. So, remember, if they mention any of these causes, they are probably mentioning about the membranous or a membranoglomeralar nephropathy, membranoproliferative glomerular nephropathy. So, as I mentioned, other other nephrotic syndromes are going to be non-selective proteinuria and they are going to be steroid resistant. So, it is going to be difficult to treat other nephrotic syndromes other than the minimal change disease. And the most troublesome part about this is that even if you do a renal transplant, this disease can recur in 40% of the patients. So, let's see the image-based questions of membranous nephropathy. So, in light microscopy of a membranous nephropathy, you see the diffuse thickening of this basement membrane. So, all of this is the basement membrane. Can you see it is all quite thick? So, all of this is called as the diffuse thickening of the basement membrane. So, all of this thickening of the basement membrane is going to be there in a membranous nephropathy. And the classical feature of a membranous nephropathy is what we see on electron microscopy or on a silver stain, which is called as the spike and dome pattern. So, in this image, if you see, I'll zoom it. So, this is the glomerular basement membrane, and on that, if you are able to see, it is all looking like something like this, right? So, this is called as the spike and dome pattern. Actually, what happens here will be, there will be the immune complex deposition, and the membrane will appear like this. So, in between the immune complexes, the membrane is going to protrude up and this is going to appear like a spike and dome pattern. So, the spike here will be the membrane actually and the dome will be the immune complex. So, this is the dome which is the immune complex. So, over time what will happen is this spike will then grow upon this immune complex again and cover up this immune complex also. So, membranous nephropathy is also a cause of this immune complex related disease only. And the best way to see the spike and dome pattern will be a silver stain. So, the best way to demonstrate spike and dome pattern will be silver stain. Since it's an immune complex disease, again, on immunofluorescence, you are going to see a granular kind of deposits. But on electron microscopy, again, you can visualize this spike and dome pattern. And basically, here also, the deposits are going to be subepithelial only. Like in a PSGN also, we saw the subepithelial humps, right? So, that was subepithelial humps. Here, it is called as subepithelial deposits or epimembranous also. So, subepithelial is basically epimembranous only. So, here, if you appreciate, these are the podocytes. And this is going to be the endothelial cell. But in between, if you are able to see, these are the electron dense deposits which are present on a subepithelial location. Okay. So, this again is going to produce this subepithelial. Next, we'll see about next type of nephrotic syndrome, which is membranoproliferative glomerular nephritis. So, here it is going to be a combination of both nephritic and nephrotic syndrome, but more of a nephrotic syndrome. And these MPGN kind of patterns are known to progress on to RPGN. So, in RPGN type 2, we saw MPGN as one of the examples, right? So, it can progress on to RPGN. So, we have three types of MPGN. based on the disease pathogenesis. So type 1 will be the most common one, and type 1 is going to be again subdivided into primary and secondary. So in primary, it is going to be immune complex mediated, which is actually with the activation of the classical complement pathway. So classical complement pathway is going to be activated in type 1 primary MPGN, and this is going to be immune complex mediated. Under secondary, we have various other causes, which was I was telling, it will be overlapping with that of a membranous nephropathy. So the examples of MPGN type 1 in the secondary causes will be SLE again, hepatitis B, hepatitis C, schistosoma, cryoglobulinemia, lymphomas like CLLs, and then alpha-1 antitrypsin deficiency and endocarditis. So remember, cryoglobulinemia is going to be one of the best examples for MPGN. So cryoglobulinemia, it can usually trigger onto either a cryoglobulinemic type of glomerulonephropathy or a membranoproliferative type of glomerulonephropathy. Rest all infectious causes like hepatitis B, C, schistosoma, all of this are associated more with membranous glomerulonephropathy than a membranoproliferative. Okay, so MGN more than MPGN. Then we'll move on to the second type of MPGN, which is type 2 or dense deposit disease. It's the new name given will be the dense deposit disease, because the deposition here is going to be on the membrane and it is going to be quite dense, and that is why it's called as dense deposit disease. And here, what is the classical point here will be there is activation of the alternate complement pathway. In MPGN type 1, it was activation of alternate and the classical pathway, mainly the classical pathway. But in type 2, it is the alternate complement pathway which is getting activated. So when alternate complement pathway is activated, what will be happening? Here, the C1 and C4 complements, which are actually part of the classical complements, so their levels will be normal. But actual pathogenesis that happens in type 2 will be, there is an autoantibody formation called as C3-Neph. C3-Neph is C3 nephritic factor. So this autoantibody C3 nephritic factor is going to stabilize the C3 convertase of alternate complement pathway. So the alternate complement pathway C3 convertase will be C3b-BB. So this will be stabilized. So when this is stabilized, continuous activation of the alternate complement pathway will be there. So the alternate C3 will be consumed. So C3 levels will go down in the blood, while the normal classical complements like C1 and C4 will be normal. Okay. So this is the pathogenesis associated with type 2. And one other MCQ here will be dense deposit disease is going to be associated with some other diseases like partial lipodystrophy and also macular degeneration. Okay. Both of this can be asked as MCQs as well. So under type 3 MPGN, here it is considered as a subtype of type 1 MPGN only, and it is also immune complex mediated like type 1. And here there is going to be deficiency of the complement factors, that is the pathogenesis involved here. So complement factor deficiency will lead to type 3 MPGN. And the location of these deposits are also going to be different. So in type 1 MPGN, it is going to be subendothelial location. Subendothelial location of this immune complexes will be seen. While in type 2, the deposition will be there on the membrane. So intramembranous deposition will be there. While in type 3, it is going to be subepithelial deposits. Okay. Let's see the image-based questions over here. So like PSGN, MPGN will also have a proliferative kind of glomerulonephritis. In fact, its other name is going to be mesangiocapillary glomerulonephritis. So there is going to be proliferation of both the mesangium and the capillaries like in the PSGN. Okay. So here again, if you see, this pink material in between is all the mesangial matrix which is being expanded. So mesangial cell proliferation is there, and these cells are going to be, or all of these darker cells are going to be the endocapillary proliferation. And when this glomerulus is being enlarged and proliferative, it is going to give a lobular accentuation. So this kind of lobular accentuation of the glomerulus is seen in MPGN. Okay. And if you use a silver kind of special stains, you can see the classical feature of MPGN, which is called as double contour or tram tack appearance. Here again, like the MPGN, membranous glomerulonephritis, you are again going to see thickening of the basement membrane. But other than that, it will also have a double contour. So I have expanded this image. If you see here, you can appreciate the membrane is all becoming double layer. So here the membrane is just thickened. It is all thickened over here, but here this area and this area, if you see, the membrane is all having a double contour and it looks like a train track. So it is called as tram track appearance. So why does this tram track appearance happen is there is going to be the subendothelial deposition of this immune complexes, right? So these immune complexes, when they deposit, they are going to have, it will appear as if it is splitting the layers of the glomerular basement membrane. So especially in the dense deposit disease, we are going to see this. So when these deposits are going to be present on the lamina densa of the glomerular basement membrane, it will appear as if the membrane is being split above this and above and below this immune complex. So that is why it is also called as the reduplication of the basement membrane. So again, the classical features of type 1 and type 2 MPGN here will be, so type 1 you will have subendothelial deposits. So here we are going to see this, these are the deposits which we are seeing. So this is the podocytes here, and these are the endothelial cells. So subendothelial location, you are going to have this deposits in a type 1 MPGN. So type 1 MPGN being an immune complex disease, it is going to have granular deposits on a immunofluorescence. While type 2, here the electron microscopy, the classical feature will be this presence of this dense ribbon-like deposits. So dense ribbon-like deposits are seen in intramembranous deposits are going to be seen in dense deposit disease or type 2 MPGN. And here the on immunofluorescence you can see both granular or linear type of deposits, which will be mostly of C3 composition. Since it is an alternate complement pathway, there is not going to be any immunoglobulin deposition. It is only C3 deposition.